All right, Chapter 18, Part 1. If you recall, we've already actually studied the latter half of this chapter, Part 2 of Chapter 18. We actually studied back in the first week, actually I take it back, second week of the course, when we talked about the different monitoring devices. This week we're going to talk about the vital signs. A lot of this, of course, will be review from your EMT course, but we're going to talk about the different vital signs that we obviously take in EMS, and hopefully we'll gather a little bit of a better understanding as opposed to just the whys, maybe a little, or just the hows, now maybe a little bit more on the whys and whatnot. As always, to simply listen to or watch this lecture does not in any way, shape, or form substitute for actually reading and studying the chapter. So if you have not done that, do so as soon as possible. So the AEMT education standard that applies here will apply scene information and patient assessment findings, including the scene size of primary and secondary assessments, patient history and reassessment, to guide emergency management. So when we are in the vital signs area and some of the diagnostic monitoring devices, we're really kind of in that transition between the primary assessment and the secondary assessment. If by the time we've completed our primary assessment we haven't completed an entire set of vital signs, the appropriate time to collect all of those or complete all of those would be at the beginning of our secondary assessment. So in the non-narrated PowerPoint, you of course will have a couple videos on the different vital signs. We have a handful of objectives, or two, actually a few more than a handful, that go with this chapter. We'll skip ahead of those. Looks like about 39 of them, but of course a bunch of these still apply to the second half of the chapter that we've already reviewed. So vital signs, assessment of the skin, pupils, and information from different monitoring devices is going to be obtained at some point during our secondary assessment, if not at the beginning, at some point during that second part there. We get a ton of information from these things. Now, vital signs in and of themselves all alone don't always tell the story, but when we couple them with the clinical signs that we see on the patient, it helps us get a better picture of what's going on. If I tell you the patient is got a heart rate of 116, well, that might start to raise your eyebrows just a little bit. And if I tell you that the patient has a history of atrial fibrillation and chronically runs high, then that all of a sudden maybe isn't so important. If I tell you the patient just got done running 5 miles, that probably doesn't seem quite as important. But if I tell you that the patient is typically has a heart rate somewhere in the 60s or 70s and is a generally healthy 21-year-old female, that should maybe start to raise a little bit of concern. So it matters on the context that we take many of these with. In and of themselves, unless the vital signs are nearing zero, most of them we can't absolutely positively say, oh, this is bad, or oh, this is good. So what do the vital signs include? Vital signs are going to include several different things depending on what school of thought you look at. Classically speaking, there really are 4 vital signs. And the 4 vital signs are pulse, respiration, blood pressure, and temperature. In some cases, we substitute capillary refill for blood pressure on the younger children, say under the age of 3. Capillary refill isn't specifically a vital sign, but it generally does give us a fairly good idea of how that person is perfusing in the periphery. Other places will also throw some other things in there, like glucometer or pulse oximetry or pain. Well, glucometer and pulse oximeter, those are diagnostics. They are not vital signs. They help us. They're a monitoring device, but they by themselves are really not a vital sign. And in most places, they consider pain to be the 5th vital sign. But again, pain is not really a vital sign. In most people, yes, they don't have pain. So, I mean, it's something that should be considered, but it isn't specifically really a vital sign. And a video on those. Okay. So we also have our electronic monitoring devices, such as electronic vital sign monitor. A lot of people call this a nurse on a stick. So you might have the luxury of having that built into your cardiac monitor in your truck, that it will take a pulse oximeter reading for you. It will take, which also gives you a heart rate usually. However, note that there are times in which a patient's actual palpated pulse, the heart rate as shown on the screen of the cardiac monitor, and the heart rate as shown by the pulse oximeter, all three vary significantly. So a pulse really truly is when you palpate a patient's pulse. That is the sign of how well blood is flowing through the arteries. Electronically, you can get one rate on the cardiac monitor, and it may not match because sometimes the physical aspect of it, the muscular aspect of it, isn't working along with the electrical. So, so if you have the capabilities, that's great, but understand that they're not always perfect. Pulse oximetry, capnography, ECG, blood glucose, we've talked about those before. If you need to, go back to week 2 and you can kind of recap those. You need to integrate your vital signs and monitoring results into your overall impression of your patient. So what have we learned about our patient? How did we initially feel about the patient, and now that we have the vital signs, does that change our general impression? Does that change the intensity or the transport priority of our patient? And that goes with your case study. So the integration of assessment of vital signs and the use of monitoring requires teamwork. I've mentioned this before in previous assessment chapters. In many cases, since we're doing this as a team effort, we aren't the only ones that are doing anything for our patient. So a lot of times we can actually rely on somebody to gather vital signs while somebody else is doing an assessment. Maybe somebody's gathering history. So a lot of times things get done simultaneously, and that's great. So we must obtain a full set of baseline vital signs. And that full baseline vital signs includes pulse and the qualities that go along with it. Now please don't take that as only saying pulse quality, but all of the qualities that go along with it are characteristics that go along with the pulse. Respirations and all the characteristics that go on with the respirations, as well as your blood pressure. And we really should honestly be taking temperatures. Back in the olden days, when I got my start, most temperatures were taken by a glass thermometer. Well, glass and running down the highway at 60 miles an hour don't always, a glass rod in your mouth full of mercury, which, by the way, it doesn't take long to become toxic in your system, isn't always the smartest idea. So in those days, electronic thermometers, yes, they were available, but they weren't by any means perfect, and especially they weren't cheap. So when we started seeing other electronic devices come around, we were able to say, okay, well, maybe we can use some of these advances in technology. You can now get a fairly inexpensive oral thermometer that you use a little plastic sheath at Walmart, for like $10, and it works well. The little strips that you lay on somebody's forehead that kind of show up a color, those are not particularly accurate or discouraged. There's the ear thermometers; those tend to not be terribly accurate. And then there's the new temporal thermometers that you kind of swipe across the side of their head and across their forehead. Those actually end up being pretty accurate, but those, of course, are the expensive ones these days. So there are the opportunities to do this out there. And as long as as short a time as it takes, and as easy as it is, and as cheap as it is, we really should be doing this on everyone. All right, we also have to prioritize tasks in relation to a patient's condition, their anticipated treatment, and other tasks. So if that being said, if there is only one of us able to take care of our patient, and it comes down to saying, do we need to ventilate the patient or do we need to take a blood pressure, ventilation wins every time because it's going to take you longer than about 6 seconds to gather a blood pressure. So to take the time out to take a blood pressure and let that patient sit there without a breath for 30 or 45 seconds, that's not a good idea. It's just really not good. So sometimes we have to wait. We have to postpone some of these things. Now, getting a pulse, fairly easy. Getting respiratory rate, fairly easy. Temperature obviously takes a little bit of equipment, but those sorts of things we have to just kind of weigh with the number of hands available. And we have to be able to communicate with our team members. Maybe somebody's in charge of the patient assessment, or maybe the team leader, the team captain, whoever is going to dictate who does what. And so the team captain may have to start asking other people to take take vitals. Remember, reassessment every 5 minutes on critical patients at least, and at least every 15 minutes on non-critical patients. So we're going to assess vital signs before and after giving medications. A full set of vital signs, really, before and after medications. So in some cases, we probably are going to be a little bit more raring to go on some of the medications. So for example, epinephrine, if we start to have the patient that's having an anaphylactic reaction, we might be trying to get somebody to take a blood pressure while we're giving the epinephrine. I mean, because that's really going to be a lifesaver there. However, another school of thought is if we hurry up and we give epinephrine to a patient who has very, very low blood pressure, they're not going to pick it up and not going to move it, because sometimes patients with anaphylaxis become hypotensive quickly, and then they don't have the perfusion to the skin to actually, and to the muscles to actually move the medication into the system. So, you know, it's definitely something we have to be considering. If we had a patient that was extremely tachycardic, we would be concerned with that before giving a patient albuterol. Oops. And then reassessing vital signs if the patient has additional complaints, increases of distress, or suspect condition worsening. I think they kind of miss the boat on here as well, and don't say as the patient gets better. So I think this is better stated as the patient has a condition change, either positive or negative. So as things improve, we're going to want to watch their vital signs as well, because that could be very telling. We could get a lot of information out of it. All right, so assessment of vital signs is integrated into patient assessment in different ways depending on the patient's condition and resources available. What patient and situational factors influence when vital signs should be taken in the patient assessment process? I think biggest and baddest time here, the factor here, I guess, is the number of hands immediately available. So if there's 3 or 4 of us that show up on a call, there's really no reason why we don't have a set of vital signs done almost at the end of the initial assessment, the primary assessment. Although that's not technically the way we do it on paper, but remember, on paper, for educational purposes, we're looking at it as a one-person show as opposed to a team effort. Additionally, if we're having to do things like resuscitative measures, so controlling bleeding, doing ventilations, putting in an oral airway, those sorts of things, those definitely take precedence over getting a full set of vitals. So there are 4 different vital signs: pulse, respiration, blood pressure, and temperature. We're going to obtain pulses and respirations on everyone. We're going to obtain blood pressures on everybody over the age of 3. We can do it on patients under the age of 3. One of the biggest issues, though, in most cases, is we may not have the appropriate size cuff for the little ones. Temperature is not routinely obtained, but like I said, it's something we should be doing. That's the full assessment, and it can actually tell us quite a bit. We do need a number of pieces of equipment for vital signs. So a watch or a clock with a second hand. Digital is fine. You can have a digital or you can have a hand, either one. If you haven't picked up on this by now, every time we have a skills day from here on out for the remainder of the course, everybody needs to come with a watch that counts seconds. A stethoscope. Everybody should probably also bring their stethoscope to every skills day. A sphygmomanometer, which is the medical term for a blood pressure cuff. A thermometer, and then a pen light. Now, pen light's not used exactly for a vital sign, but pupils tells us a lot about disability. So pen light is a key piece of information when it comes to basic patient assessment. So places in which we can locate a pulse. The temporal artery, which is lateral to the eye orbit, so basically between, it's almost halfway between the top of your ear and the corner of your eye. Just about halfway in there, maybe up just a hair, you could find the temporal artery. The carotid artery, of course, in the neck. Remember, this is medial and below to the angle of the jaw, so basically taking your fingers, putting it on the Adam's apple, pulling it down until it hits a muscle, and in a little groove there that's created by that muscle between the Adam's apple and the muscle is where you should be able to find that. The brachial pulse, just medial to the biceps tendon. So if you go, you find your bicep, which is the upper muscle, the muscle towards the front of your arm. You've got the tricep, which is the muscle on the back of your arm. You kind of find that little groove between the two on the inner aspect of it, or the medial aspect of it. You should be able to find the brachial artery there between the bicep and the tricep. We have the radial artery, which is, and what everybody's familiar with that one. The radial one's the one that we check the most commonly. But if you would draw a line straight down from your index finger just past where the thumb meets up with the wrist and the radius, where you'll find the radial artery. The ulnar artery, same basic location, except draw a line straight down from your pinky finger, and that's where you'll find your ulnar artery. They're on the soft side of the wrist, not the lateral sides of the wrist or the bony parts, just on the inside where it's a little bit soft and fleshy. Femoral artery is just below the inguinal ligament. I like to say if somebody's wearing a pair of briefs, it kind of runs along that line, or where the crease between the groin and the leg is, just on the inner aspect. Almost if you put your wrist right on your hip bone and lay your hand directly down that crease, just about where your fingertips will come is pretty close to where you'll find your femoral artery. Popliteal, just behind the knee, and it's on the inner aspect of the knee. The picture doesn't do it very good justice. It shows it more outer. It's actually more inner. You have the dorsalis pedis on the top of the foot, so if you draw the big toe upward towards the ankle, it's on the lateral or the outer, just lateral or outer aspect of that ridge as it comes up. And then you have the the posterior tibial, which is right behind your ankle bone on the inside. So inner ankle, just behind the bone. There are others. There's the mental artery, a very small artery that runs right along your front of your chin. And I mean, we could keep looking. There's one more that's not demonstrated here, the apical artery, or apical pulse. An apical pulse is one that you actually assess by auscultation, not by palpation. So the apical pulse, you take your stethoscope and you lay it right over the heart, and you listen for the lub-dub, and you can count how many times the heart beats. It doesn't always coincide with a palpated pulse. So remember, the pulse is an intermittent wave of pressure that's felt in the arteries as a result of the left ventricular systole, or the contraction of the left ventricle, and it gives information about the cardiac function and tissue perfusion. So when we have a good radial artery, radial pulse, or even a popliteal, or one of the pedal pulses, they give us a very, very good idea that, hey, we're getting good, decent blood flow out to the extremities. Now, whether or not it's actually getting into the capillary beds, that still remains to be seen, but in most cases, if we've got a good distal pulse, we probably have a good chance of having some good tissue perfusion. So, peripheral pulses are assessed in responsive patients and central pulses in unresponsive patients, with the exception of the infant. And the infant patient, we check all of them in the brachial artery. So just above the anacubital fossa between the bicep and the tricep in the infant patient. But in responsive patients, generally we're looking for a radial pulse. Otherwise, we're going for the carotid. So here they're checking a brachial pulse in the anacubital fossa. Technically, when you are assessing that or finding that on the patient, that's where you actually should be placing your stethoscope when you're going to check a blood pressure, is right over where you feel the pulse there. So you can take and put your fingers kind of about two-thirds the way toward, two-thirds the way in or one-third the way out. So a third the way from the inner aspect of your elbow. You should be able to find the brachial pulse, and you can trace it on up, and it goes up right between the bicep and the tricep. But that's the artery you're listening to when you're taking a blood pressure. So in the unresponsive adult, we're checking it in the carotid artery, and the carotid artery there in the neck. And hopefully everybody's familiar with this, but you, again, find your Adam's apple. Slowly slide your fingers towards the side till you hit a muscle there, which is a sternocleidomastoid muscle. And in the little groove, the little soft divot or depression there, is where you'll find the carotid pulse. Do not feel on the outside of it or the lateral aspect of it, because then you have to feel through a muscle to find that pulse. So getting into the soft spot, you have the easiest access to it. If we have a critical unresponsive patient without a radial pulse, we might also check the femoral pulse. And that femoral pulse in the adult patient is generally, it's a very large artery, but it is still kind of difficult to find. So it's not an easy process to get that always. There's discussion, and it's really more rule of thumb than anything. There's no real scientific backing to it, that they say if they have a radial pulse, their blood pressure is usually at least 80 systolic. If they have a femoral pulse, it's usually 70 systolic. And if they have a carotid pulse, it's usually at least 60 systolic. That is not a hard and fast rule, but I guess it kind of shows you that as a patient starts to shunt more and more blood to the core, you see the shunting of blood from the radial, then from the femoral, and then finally from the carotid. So again, assessing the small child, we can check that in the anacubital fossa by checking the brachial pulse. In the infant, it's a little easier to find that in the upper parts of the arm there, because there's just not the muscle mass. So you can find that really anywhere along where you can find the humerus. So things we're looking for when assessing the pulse. We're not just looking for a rate. And this is something I think that gets forgotten about very, very commonly. So please commit to memory. We're looking for a rate, we're looking for a rhythm, a volume, and a strength. So multiple characteristics we're looking for. Remember, you also have to vary your approach. So we tend to press lightly with the tips of our index and middle fingers over the location of the artery to find the pulse. Sometimes we push a little harder, sometimes we push a little lighter, until we find a good, reliable pulse. So you might have to vary your approach to it. Once you get a good, reliable pulse you are confident that you're feeling, then you will start to count pulsations, and generally we'll count them for 15 seconds and multiply by 4. You can count it for 30 and multiply by 2. You can count it for 60 and not have to multiply at all. You can count it for 10 and multiply it by 6. So you can multiply by, or count it for 6 and multiply it by 10. The longer you take it, though, the more specific it will be. The more accurate it will be. So sometimes we have patients with very irregular pulses, and if you have an irregular pulse, you could get in the spot, count the 15 seconds in which their heart was beating slower, and come to find out that their heart rate was actually much faster because you only got the little snapshot. So the normal heart rate in an adult is 60 to 100 beats per minute, which really should not be earth-shattering to anyone. In tachycardia, we have a heart rate that is faster than normal, so 100 or greater. Things that will drive it to become tachycardic will include anxiety, fear, pain, blood loss, dehydration. So right there we see blood loss, dehydration, fever. All those things tend to go with some of the types of shock we've discussed. Hypoxia, heart failure, caffeine or other stimulants, and certain cardiac dysrhythmias will cause you to have some tachycardias. There's a little chart on the normal pediatric vital signs. We've talked about that before. As we age from newborn to adulthood, our respiratory rate, heart rate tend to go down while our blood pressure tends to go up. Temperature tends to stay about the same. So additionally, as we're assessing the pulse, blood pressure might drop, the tissues might not be adequately perfused. You see this, say, in MIs, congestive failure, particularly those that are headed towards cardiogenic shock. So we also need to take a moment and look at the bradycardic side of things, where we have a slower than normal heart rate. And this too can cause there to be inadequate tissue perfusion, simply for the fact that it's just so slow, it's not getting nearly enough blood moved. So we have this slower than normal heart rate. The cardiac conduction system sometimes gets worn out, just like car parts. They wear out over time. The older they get, the greater chance of failure. Excessive stimulation of the vagus nerve. So that's that nerve that's behind your carotid artery. If you rub on your neck, it can slow your heart rate down. This is actually one of the reasons why the sleeper hold works, is they actually will put this pressure on the vagus nerve. It slows the heart rate way down. And then reflex response to hypertension. So the body says, whoa, there's too much pressure here. Slow the heart rate down. If we slow the heart rate down, then we're not pumping blood as fast, and hopefully the pressure starts to fall. We also see sometimes Cushing's reflex causes this. So it's combined with hypertension, bradycardia, and then one more is irregular or erratic respiratory drive or respiratory pattern that tends to go, it's called Cushing's reflex. So that combination of hypertension and bradycardia in the patient with the brain injury. All right, bradycardia can also cause this decrease in cardiac output, causes hypoperfusion, can cause hypotension. Irregular pulse does not necessarily mean all is well, and an irregular pulse does not always mean that they have life-threatening condition. We'll take, for example, atrial fibrillation. Atrial fibrillation is what we often call the nursing home rhythm by nickname. If you want to look at the bottom of page 457 in your text, you'll see an example of atrial fibrillation down at the bottom there. Put a bookmark or put your finger in there for just a second, and I'm actually going to have you look towards the back of the textbook in that little section where we have cardiac rhythms. And as soon as I find it here, I'll tell you which pages to look at. There we go. If you look at page 1086. Nope, take that back. Look at page 1084 and then 1082. So if you flip back and forth between 1082 and 1084, 1082 top picture is normal sinus rhythm, which is what the norm is. And then 1084, bottom of the page, that's atrial fib. So you see what's missing, what's different there mainly is that it's now an irregular rhythm. The rate can bounce all over the place. And the other thing that you note the most about atrial fibrillation is it doesn't have the nice pretty pattern in between. So we're missing what's actually referred to as the P wave in front of the QRS. The QRS is the big spiky part. The P wave is the little hump that precedes the spiky thing. So if you look at 1082, you see there's P waves, there's a big spiky thing, that's the QRS, and there's another hump just after it, and that's called the T wave. So in atrial fibrillation, we don't have the P wave. We actually have hundreds of what are referred to as F waves or flutter waves or fib waves. And these fib waves cause that kind of really irregular fuzzy baseline. And okay, you can flip back now. But what that means, what that's actually showing us, is the top part of the heart is very irritable and firing off all kinds of little sparks all at once, and literally can be hundreds of times in a minute. And there's no coordination there. So I think it's not a bad little demonstration, I guess, what they show you on 457. The heart that they show you there, they've got all these little stars kind of blinking, and it's all completely erratic. It's not a nice, even pattern. So that's AFib. And the thing about AFib is irregular. And the classic way we describe it is it's an irregular. So there's not a pattern to it. It's all completely erratic and spontaneous. All right, assessing the pulse, we're looking for pulse volume, which is a reflection of the arterial diameter, or how full. Is it a nice full pulse? A lot of times we'll equate that with the strength. Strength is an indication of blood pressure. And then we may have a thready pulse, which is typically a weak and more times than not, it is also a rapid pulse. And then under most circumstances, we consider the patient have a strong pulse. So thready versus strong is really what we will refer to it as when we're looking at that characteristic of the pulse. We may also look at some things such as we talked about the regularity of the pulse. So we have the rate of the pulse, the depth of the pulse, and the regularity of the pulse. So those are all those major characteristics that we're concerned with when it comes to checking pulses. So that volume versus strength, we usually will describe it as either strong or thready. So as we move into blood pressure, the blood pressure, this is the amount of force exerted against the walls of the arteries by blood flowing through them. And there are two measurements that we get, the diastolic and the systolic. I'll talk about those here in a second. It is measured in units of millimeters of mercury, so little m, big H, little g. And we have adequate blood pressure is required for tissue perfusion. If we don't have blood moving through the system on a regular basis, then we don't have blood making it to the end organs. We don't have blood making it to the tissues to take the goods in and the bads out. Chronic high blood pressure, on the other hand, causes tissue and organ damage because the heart has to beat harder, or it's exerting much more force on the arteries that are flowing, say, through your kidneys or through your liver, even through your lungs. Those sorts of things cause the arteries start to break down and have issues. And there's a video on blood pressure. So blood pressure is going to depend on a couple of things. Number one, volume of the blood available. If we don't have blood in the system, doesn't really matter how hard the heart beats, doesn't matter how tight the vessels are. The effectiveness of the heart as a pump. So does the heart have the strength to keep moving the blood? And then the capacity of the vascular system at the moment, so the size of the vessels. So we have systemic vascular resistance. We've talked about that before. So we have to have the blood, we have to have the pipe, we have to have the pump. So if we don't, then we will have an insufficient blood pressure. So systemic vascular resistance, if you want to remember what that is, SVR. Don't forget about stroke volume. Stroke volume is the amount of blood that's pumped in any one pulsation of the heart. We have cardiac output, which is generally seen as the stroke volume times the heart rate. So cardiac output of 50, 60, 70 milliliters a minute times however many times per minute our heart beats. So if we say 60, we say 60 milliliters times 60 beats per minute. That's 3,600 mils a minute. So we also have the concept of mean arterial pressure, and that mean arterial pressure is really it ultimately is really what we're looking at in patients when we check their blood pressure. We don't often look at it specifically. We don't usually calculate it. If we have a cardiac monitor or a nurse on a stick that does this, it'll automatically calculate it for us in many cases. It's sort of kind of an average, although it's not exactly an average. It is a central tendency, but the common way of estimating your mean arterial pressure is to add 1/3 of your pulse pressure to your diastolic. 1/3 of the pulse pressure to the diastolic. Yeah. And so in a person with a blood pressure of 110/80, and you can find this on 459 in your text, a person with a blood pressure of 110/80 has a pulse pressure of 30, because that's the difference between the systolic and the diastolic. So 110 minus 80 is 30. So 1/3 of that would be 10. 1/3 of 30 is 10. And then we add that to the diastolic. So the diastolic is 80. So it gives us a map of 90. So map equals 1/3 the systolic minus the diastolic. And then add that to the diastolic. So that mean arterial pressure is what gets used more times than not in, say, the ICUs. That's what they're really looking for, is mean arterial pressures. And that's telling them really how well are they circulating, how well are they perfusing. So in many cases that's really what their big marker, as opposed to the actual blood pressure. All right, cardiac output, still talking about that. Systemic vascular resistance, this is based on the diameter of the blood vessels. So how big are your blood vessels? We've done the demonstration of the garden hose versus the fire hose, same amount of fluid running through them. Which one moves easier? Well, it's easier to move through big, wide vessels than it is to run through little, tight vessels. But it also puts it at a higher pressure. So during each cardiac cycle, that blood pressure is highest during ventricular systole, hence where we get systolic blood pressure. So it is the higher pressure associated with ventricular contraction. So the amount of pressure inside the vessel walls with the heart at work is the systolic. The diastolic then is when the ventricle is at rest, or it is relaxing and refilling. So that is the diastole period, or and that's where we get diastolic from. So we have a systolic blood pressure of 100 to 140 and a diastolic range typically of 60 to 90. Those are quote-unquote normals, although this kind of varies. There's recently been some studies that have come out that have suggested that maybe we're just a little bit too strict when it comes to higher blood pressures in adults. Maybe they've been too conservative and are now starting to say it is permissive to allow a person to have a little bit higher blood pressure than we previously said. So to define a couple of terms that go along with blood pressure: hypertension, hypotension. Hypertension would be a person with a above normal, so above 140 systolic. Hypotension, somebody with a below normal, so less than 90 or 100, depending on protocol, for a systolic pressure. Pulse pressure, again, the difference between the systolic and the diastolic. We have pulsus paradoxus. This is when the blood pressure, systolic blood pressure, drops greater than 10 millimeters during inspiration. This occurs for a couple of reasons, usually when there's excessive pressures around the heart. So in most cases, cardiac tamponade, sometimes with like a tension pneumothorax, you may have a pulsus paradoxus. And what happens is when you have inspiration, you add more pressure around the heart. The heart can't expand well, so therefore drops that blood pressure. So that's pulsus paradoxus. And then pulsus alternans, which is not listed here on the screen, but pulsus alternans, this is an alternating pulse specifically due to left ventricular failure and is not related to breathing. So pulse gets weaker during inspiration. That's the pulsus paradoxus. Pulsus alternans is an alternating pulse. So it's weak, it's strong, it's weak, it's strong. Or it speeds up, slows down, speeds up, slows down. All right, so here we have applying the blood pressure cuff. The blood pressure cuff or the sphygmomanometer, to be correct, you need to apply the bladder of the cuff where you can see the white label there says artery. The bladder of the cuff needs to be over the brachial artery. So even to rotate it inward a little bit more wouldn't even be a bad idea. If you have the bladder on the outside of the arm, you are not getting an appropriate or an accurate reading. The bladder must be over the artery. If it's not over the artery, you have a incorrect blood pressure. So, and they have the stethoscope placed there over the antecubital fossa. Remember, I told you to find the brachial artery, the brachial pulse there, and apply the stethoscope head right over the top of that. You may have to vary your pressure of your stethoscope head over the top of your brachial artery in order to get a good quality sounding pulse. Now, you should not be able to hear the pulse before you even pump up the blood pressure cuff. Remember, we usually start with nothing. We hear the beat, 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 which are called carot cough sounds. We hear the carot cough sounds, and then they slowly go away, and then we have nothing. And that's how we get our systolic over our diastolic. First time we hear a carot cough sound, a good steady carot cough sound, is the systolic. The last good steady carot cough sound we hear is the diastolic. I'll back up to that for just a second. I would not place your fingers over the backside of your stethoscope head like that. A lot of times doing that, even if you have a little bit of movement in your fingers, you actually kind of get some of that creaking sound that kind of resonates through that stethoscope head. So it's better to actually place your fingers off to the sides. So kind of hold it in the V of your finger as opposed to with your finger or two over the bell or the smaller diaphragm of the stethoscope. So we need a stethoscope and a sphygmomanometer in order to check an auscultated blood pressure. We have an alternative called a palpated blood pressure, but and there's the carot cough sound. The carot cough sound. This is the force of first pulsations of the blood pressure that exceeds the pressure in your cuff with the stethoscope. So the carot cough sounds are those pulsations that you hear, those beats that you hear. So assessing the blood pressure, when palpating the blood pressure, the pulse in the radial artery is palpated as the cuff is deflated. This gives us a pretty close guesstimation. The guesstimation that you're getting is usually plus or minus 10 millimeters of mercury to what the actual blood pressure is. And more times than not, it's closer than it is further. We prefer a blood pressure by auscultation. It's more accurate than to palpation. In most cases, it's difficult for us to hear a blood pressure going down the road, so our first blood pressure tends to be by auscultation. And then when we're in transport, in many cases, we're taking blood pressures by palpation. As long as you're within a few millimeters of mercury by palpation, you can generally say, okay, well, it looks like we're staying stable here. It looks like we're not having a significant change. And then capillary refill is also assessed, and that helps us to indicate peripheral perfusion status. And like we said, we do that more in the pediatric patient. It does work in the adult patient, but there are plenty of things that happens in the adult patient that may not make capillary refill quite as accurate as we'd like. Things like arterial sclerosis, where you start to get some hardening of the arteries. You may also have a person who's a smoker, or patients who take other certain drugs that cause significant vasoconstriction. They might be very cold, and those sorts of things will kind of alter capillary refill. So it's going to walk us through the process of taking a blood pressure by auscultation. So tell them what we're doing. Position the blood pressure cuff around the patient's arm, the bottom edge about 1 inch above the crease of the elbow. The cuff should be snug and the marker on the cuff in line with the brachial artery. Locate the radial pulse with your fingers, and then keep your fingers on it. Close the valve of the inflation bulb and inflate the cuff by squeezing the bulb several times while firmly watching the needle on the gauge, and inflate the cuff 20 millimeters of mercury beyond the point in which the radial pulse disappears. So there's a lot of people who think that, oh, well, just throw the blood pressure cuff on, we'll pump it up to 160 or 200 or 340, and then start letting the pressure out. And that's not the best way to do that. It causes excessive amounts of pressure on the tissues that are not necessary. Once that we're 20 millimeters of mercury above the point in which the pulse disappeared, we'll take the head of our stethoscope and place it as demonstrated there. And you can see he has his fingers V'd around the sides of the bell of the stethoscope, so that's the better way to do that. And then place that diaphragm over the brachial artery there. Slowly let some air out, and then we're going to watch. We're going to deflate the cuff at a rate of about 5 to 10 millimeters of mercury per second. 5 would be better, 10 would be less accurate. And then listen for the carot cough sounds. Position the gauge so you can, when you hear the first sound, you can note very quickly at what point that was. So, and then quickly, and then after you, I like how they put that there. When you hear the last sound, that is the diastolic blood pressure. So the first good steady carot cough sound is the systolic. The last steady regular sound is the diastolic, and then you can release the remaining air from the cuff. We also might want to talk about orthostatic vital signs. And orthostatic vital signs are useful but time-consuming information, and often can become kind of a dangerous situation to be in. So orthostatic vital signs are typical in patients that are becoming hypotensive for various reasons, and in many cases it's due to things like GI bleed or another type of hemorrhagic shock. Orthostatic hypotension, or sometimes called postural hypotension, occurs when we change from a prone to a standing position. From prone, actually can be also from supine, so from lying down to a standing. So from 300 to 800 milliliters of blood can move into the lower extremities when a patient moves from supine or prone to standing. So the body, that's actually normal. So the person should have, sometimes we'll have to take a moment to kind of redistribute. Sometimes you probably feel this as well, where you start to get a little lightheaded, kind of get that little head rush going on. So to take a set of orthostatic vital signs, a patient must lie in a supine position for at least 3 minutes to kind of get their body to kind of become accustomed to that position. And then after you take the patient's blood pressure and heart rate, leave the cuff in place, have the patient stand for at least 3 minutes, and retake the blood pressure and the heart rate. They are orthostatic, or postural hypotension, is when we have a drop of the systolic blood pressure of at least 20 millimeters of mercury or more, or an increase in the heart rate of at least 20 per minute or more. And then 3 minutes after, the patient assumes an upright position. So if you have the person who's lying on the floor take their blood pressure and their pulse rate, and then you have them jump up, and they've been laying there for 4 hours, and then you have them jump up, and 10 seconds later you take another blood pressure and pulse. Of course it's going to be different. The body hasn't adjusted. Body hasn't done its thing to kind of redistribute. So that's typical. So a lot of times people leave that out when they're checking orthostatic vital signs. They forget they got to wait a couple minutes in between there in order to make sure that it gives you a true positive as opposed to that false positive. Certain medications that prevent vasoconstriction, such as a lot of blood pressure meds or some antidysrhythmic meds, can cause or it actually will help decrease the ability for their heart rate to jump up, can mess with this. So they may not be able to constrict quite as much as they thought. But in most cases, they're orthostatic when they have dehydration, blood loss, and occasionally some of the medications actually turn around and cause some orthostatic issues as well. So that orthostatic vital signs, here's that classic description again. So after 3 minutes, becoming upright, they have a systolic blood pressure of 20 millimeters of mercury or more decrease, or an increase in heart rate of more than 20 per minute or more. Now, as soon as I say that, I want to tell you that we will consider in EMS the patient to be positively orthostatic if we take them from lying down to sitting up or standing them up and they immediately pass out or feel like they're going to pass out. If that's the case, we're going to take the general assumption that they are orthostatic, and we are not going to hold them upright for 3 minutes in order to actually take a blood pressure and a pulse. So if that's the case, then we're going to consider that a positive orthostatic. All right, assessing respirations. A physiologic process requires ventilation, external respiration, and internal respiration. So we're actually looking specifically at the ventilatory rate. We cannot actually tell you whether they are respiring. We can't tell you if the gas is exchanging. We have an idea, but we don't have a quantitative measure. So for effective ventilation, it requires us to have a functioning brainstem, requires us to have a functioning nerve pathway that feeds the diaphragm and the chest wall. We have to have integrity of the chest wall and the diaphragm, so they have to be intact so they can move in and out, up and down as they're supposed to. We have to have contact between the visceral and the parietal pleura, so they have to create that kind of vacuum more or less in order to keep the lungs from collapsing. And then we also have to have an open airway. If we don't have an open airway, air doesn't move in and out, and it makes it much more difficult for us to move the air from the outside environment to the inside world. Our stimulus that starts our respiratory cycle is an increased amount of carbon dioxide in the blood. That is our normal. People with COPD actually operate off of what's referred to as the hypoxic drive, and that's the backup system. The backup system, I mean, their body has been tricked for years and years and years that the high carbon dioxide level is going to be normal because they're smokers. So their body goes, I'm going to stop paying attention to it. Well, eventually they develop the COPD, and their body just no longer pays any attention to CO2. They all look for low O2 levels, and that low oxygen level becomes their stimulus. But in most cases, it's high CO2. Movement of air during ventilation is based on an inverse relationship between the volume and the pressure of the gas. And the movement of the air out of the lungs is called exhalation. Inhalation is an active process. Exhalation is passive. Active requires energy, requires us to actually do some work. So inhaling requires your body to work. Exhalation is passive, meaning that everything just relaxes and goes back to its normal state. And then ventilation is controlled by the autonomic nervous system. So autonomic is our vital functions.